Hi friends. Welcome to Dentistry Love channel, Avulsion a complete summary. Here we gonna see intro, prognosis, indications, contraindications, complications, additional considerations, step-by-step description of procedure, storage media, aftercare, warnings and common errors. An avulsed permanent tooth is manually reinserted into its socket as soon as possible after the avulsion. A temporary splint will immobilize the reimplanted tooth, promoting restoration of the periodontal ligament. Avulsed teeth that are quickly replaced, less than 30 minutes, have a good prognosis and are often retained, although most ultimately require a root canal. The longer the tooth has been out of the socket, worser the prognosis and is usually considered not worth trying after about 3 hours. Indications: unavulsed, extruded, laterally luxated, or severely subluxed. That is, mobile, painful, and possibly bleeding, permanent tooth. Contraindications: primary tooth involvement, intruded tooth, pushed deeper into socket, significant alveolar fracture, socket damage, or fractured or grossly decayed permanent tooth, moderate or severe periodontal disease in the area of the injured tooth, prolonged time out of socket, greater than 2 hours, congenital cardiac defects, immunosuppression. Complications: tooth may detach and be aspirated. Long-term complications include inflammatory root resorption or ankylosis of tooth, union of root to socket by bone, rather than by PDL attachment. Additional considerations: prognosis for reimplantation depends on survival of cells of the PDL. Handle the tooth only by the crown, do only gentle rinsing, and don't hold, manipulate, or scrape the root. Doing so may remove viable PDL fibers. Antibiotic prophylaxis for endocarditis should be given to certain high-risk patients who have had an avulsed tooth replaced. Patients unable to cooperate with procedure, typically children, may require sedation. Step-by-step description of procedure. Initial assessment and preparation. If anesthesia is needed, reinsert an avulsed teeth. Stabilize a mobile teeth. Reduce a luxated teeth. Splint the reduced teeth. Initial assessment and preparation. Handle the tooth only by the crown and don't disturb any of the root's tissues. If the tooth has been out of the socket less than 20 minutes, immediately reimplant it. Gently rinse the tooth with saline to prepare a space for the root. Remove the bulk of the clot from the socket using gentle irrigation and suction, small-tipped. Don't waste time trying to remove the entire clot. If the tooth has been out of the socket greater than 20 minutes but less than 2 hours, soak the tooth in HBSS, the preferred treatment, for 30 minutes to revitalize the cells of the PDL fibers, then reimplant the tooth. If HBSS is not available, milk can be used, but is less desirable. Saline is an even less desirable alternative. Remove the clot as described above if anesthesia is needed. For most lower teeth, do an inferior alveolar nerve block. For most upper teeth, do supraperiosteal infiltration. For the frequent anterior permanent tooth avulsions that occur in school-aged children without other significant trauma, local infiltration over the socket usually provides adequate anesthesia and is faster than a nerve block. Reinsert an avulsed teeth. Holding the tooth by the crown, gently insert it into its socket in correct anatomic orientation. Gently push the tooth into the socket, pressing on the crown to seat the tooth but without compressing any tissues at the root. Use digital pressure only. Check bite. Have patient gently and slowly bite down to be sure opposing teeth don't move the reimplanted tooth. Readjust position of tooth if needed so that the patient can bring the teeth together normally. Splint the tooth. Stabilize a mobile teeth. Gently move the crown to reposition the tooth to its correct location, but don't compress any tissues at the root. Splint the tooth. Reduce a luxated teeth. Use digital pressure as needed to reposition the displaced tooth into its correct anatomic position. Use adjacent and opposing teeth as guides. Gentle force abstraction in a forward direction is sometimes needed for palatally displaced teeth. Check bite. Have the patient gently and slowly bite down to be sure opposing teeth don't move the repositioned tooth. Splint the tooth. Splint the reduced teeth. Splinting of avulsed teeth can be done using composite and flexible splints, taking the support of adjacent tooth on either side. Fiber splint, titanium trauma splint. Wire has a diameter of no greater than 0.3 to 0.4 mm. 26 or 28 gauge wire, 0.017 into 0.025 inches. Orthodontic steel wire, fishing line splints. Storage media used for avulsed teeth. HBBS and other variants. Milk and related products. Saliva and variants. Synthetic products. Saline and variants. Natural products other than milk. Specialized media and other products. Aftercare at first visit. Give tetanus prophylaxis if needed. Antibiotics are usually appropriate, example, amoxicillin 500 mg TID for a week, or weight-adjusted dose for children. Very gentle warm saltwater rinses can be done every 3 to 4 hours while awake until follow-up. Gentle brushing after meals directed away from the gum line, and a chlorhexidine, 0.12% 30-second rinse is done with spitting twice a day while the splint is in place. The patient should not chew on the affected side, should ingest only liquids and soft foods, and should avoid hot and cold foods. Warnings and common errors. Do reimplantation within 30 minutes if possible. Reimplantation done after greater than 2 hours has a very poor prognosis. A tooth contaminated by dirt is a risk factor for tetanus, so immunization history should be checked. Thank you friends. Please do subscribe for more videos.